We're starting recording. We're going to have time for Q&A at the end of the program. All of the materials, as I mentioned before, there's a PDF file of this presentation that Sarah just put up on the website a few moments ago, so you can access it there now and into the future. We will also have a handout, a two-page fact sheet that we produce for each one of these programs. That has also been posted to our website, and if you're on our mailing list, then you will be getting that as well as an invitation to the next program. If you don't get it already and you would like to, the email address is Sarah, S-A-R-A, at L-T as in Tom, C-C-C.org. And then lastly, for Ombudsman volunteers in New York State, if you would like us to let your supervisor know that you attended this program, please stay on to the end of the program. There is a link that we have for a very short survey that you can take, and then we will forward that information on to each of the local Ombudsman programs. So without further ado, we're going to get started on today's program. I just want to mention, and I will probably mention this a couple times, as you can imagine, there are a lot of requirements in regard to abuse and neglect and exploitation in nursing homes. I'm going to try to cover some of the ones that I think are most relevant, but there's plenty of them. We have more information always on our website. Again, that's nursinghome411.org. And also, I realize that the program is pretty intensive in terms of there's a lot of substance, but there's no reason to worry about taking notes or remembering everything. As I said before, we have a fact sheet that summarizes some of the most important details, and then this program itself, the PDF, as well as a recording of the program, will both be available on our website. They're free to use, free to share any way that you see fit, and to any extent that I or LTCCC can provide you with technical assistance, we'd be happy to do that in the future. So, as usual, I'm going to start off a little bit about us and about the nursing home requirements and the nursing home reform law. So LTCCC, the Long-Term Care Community Coalition, we are a nonprofit organization. We're entirely dedicated to improving care and quality of life for people who live in nursing homes and other long-term care settings. Our focus is policy analysis and systems advocacy in both New York State and nationally. And in addition to that work, we try to do as much as we can in activities like this to educate consumers and families and ombudsmen and other stakeholders who work with residents and their families to help them know what the regulations, what the standards are, what the law is, and how they can use that to advocate for themselves. And then just a little bit about me. I've been with the coalition since 2002. I'll have my 15th anniversary in November, and I've been the executive director since 2005. But what we're going to be talking about today is I'm going to, as I always do, start off with a brief background on the nursing home system, how it works, and the nursing home reform law. And then the focus today is on requirements for ensuring that residents are protected from abuse and neglect. So a little bit about the nursing home system. So almost every nursing home in the country participates in Medicaid and or Medicare. And when we say participate, that's the word that the government uses. That means that they accept Medicaid or Medicare, or usually both, for some of the care that they provide in their facility. In order for a facility to participate in Medicare or Medicaid, it agrees to meet all of the standards provided for in the nursing home reform law. That's the reform law from 1987. Now, states can have additional protections, but no state can have less protection. So everything that I talk about in these programs, including today's program, goes to the federal requirements. If I ever discuss anything that is a state requirement, I will mention that it specifically applies to that state. Importantly, federal protections are for every single resident in the facility, whether you're a Medicaid resident, whether you're a Medicare resident, private pay, your uncle pays, doesn't matter. everything that we talk about goes to, every protection goes to care for everyone. I'm just going to mute everyone again because it sounds like we had some people that, joined us, and I want to make sure that everyone can hear. Just 1 second, please. Okay, someone. There we go. Okay. And then lastly, the federal agency, the Centers for Medicare and Medicaid Services, CMS, they contract with every state. Usually it's the Department of Health or Department of Public Health. Here in New York, it's the State Department of Health. And they, for two things. One is that they contract with the states to pay nursing homes for their Medicare and Medicaid residents. And they also pay those agencies to ensure that residents are protected, that all of the requirements that we talk about are realized, and it's supposed to be for every single resident, every single day, 24 hours a day, 7 days a week, 52 weeks out of the year. So this is something that is a very important issue for us. It's not just that residents are protected and that those requirements are met when the surveyor is, the nursing home inspector is in the facility. It's that this is happening all the time for residents. That's what we pay for, and that's certainly from our perspective, and I hope from everyone's perspective, what every resident deserves to have. So a little bit of a background about the nursing home reform law. Again, this is from 1987. It's still in effect. The law requires that every nursing home resident is provided the care and quality of life services sufficient to attain and maintain his or her highest practicable physical, emotional, and social well-being. And the reason why I emphasize that, as those of you who have been on the program before, to me it's a mouthful to say highest practicable. What does that mean? That means that it's the highest attainable for that person, that resident, as an individual, based upon her clinical status, based upon his needs and desires, etc. So it means that what they are able to do, what they are able to achieve, given what's going on with them clinically, and conversely, it means that they should not diminish emotionally in terms of their social well-being, and of course in terms of their health and clinical well-being, because the facility did not provide the services necessary. I like to use an example of my Aunt Hilda, who was in a nursing home for many years at the end of her life. And she used to go, she was in her 90s, and she would go for occupational therapy. And they would walk her, help her walk up and down the hall. I think it was a couple times a week. And my aunt and my mother used to laugh about it because she was in her 90s and she was not going to have another occupation again in her life. But what that means is, and what they were doing is, they were providing her with the services that she needed to ensure that she did not lose the ability to walk. She was able to walk, and there was no reason for her to lose the ability to walk. So it's just one example, but I think it illustrates that's what we talk about in terms of highest practicable, and that's what every resident has a right to expect. So the nursing home reform law, as I said before, passed in 1987. The regulations came out about 4 years later in 1991. So what's happening now, and one of the reasons why we're doing these programs now, is that for the first time in 25 years, the entire federal regulatory system is being revised and updated. And this is going to affect everything that goes on in a nursing home in terms of resident care, resident services, how we evaluate how a nursing home is performing for each of its residents, etc. So this is really, I can't overstate, how important I think this is. And here are a couple of reasons. One, that all the regulations are changing. So for 25 years, since 1991, everyone, the nursing home, the surveyor, the inspector, ombudsman, and advocates, we all knew what the rules were, we know where to find them, and now that's all changing. So that just structurally is going to make things, I think, much more difficult, at least for the next couple of years, for people to know and be able to access, well, what should be going on here? What should I be expecting? All of the guidelines are changing. So the guidelines are what it's called sub-regulatory language. Basically, guidelines detail what is expected when we talk about a regulation, we talk about a standard. So, for instance, when we say that the regulation says that every resident with dementia is supposed to be receiving the care and the services that he or she needs, again, to achieve his or her highest practicable well-being, emotional, physical, etc. So what that means, what the guidelines will say, is that there are certain expectations in terms of activities. There's certain expectations in terms of how we treat someone who has so-called behavioral symptoms of dementia, that we don't just give them drugs, that there are requirements in the guidelines for non-pharmacological approaches to care. And that's something we've talked about in the past, and we'll certainly talk about again. We have a terrific toolkit on our website for dementia-related standards and advocacy. But that's just one of the ways in which you can see it really fleshes out. So it's not just provide good care for people with dementia, it's we expect you to be undertaking non-drugging approaches to helping people with dementia, helping them to lead good lives, helping them to overcome when they're upset or acting out in some way. Next, the nation's survey system is changing. So starting this November, all state survey agencies across the country will be utilizing a new survey process. And then lastly, the FTAG system is changing. Now, FTAGs, when a surveyor goes into a nursing home and is looking to see if they are meeting the standards, each regulatory standard has an FTAG assigned to it. So if I see that someone is being, say, chemically restrained, being given a drug to sedate them, that was always called F222. So you imagine that you're an inspector, a surveyor, and you go in there, you know immediately where to find that FTAG, what it means, and how to cite it. The reason why I mention it here, why I'm taking the time to do it now, is because that also is changing. All the old numbers will be gone as of November 28th of this year. So what concerns me and what I wanted to express here is that you have a situation now where the language has changed. It's in another place in the regulations quite often. The guidance has changed, and the FTAG system. So it's going to make it much more difficult, I think, to efficiently identify and cite problems. And one of the issues that we've always seen as advocates and as policy researchers is that there tends to be a significant under-citation of problems. That problems exist, but they're not often cited. So we're concerned as advocates that that could be exacerbated, particularly over the next coming years as people get used to the system. And that's why I wanted to take a few minutes just to let you know, no reason to memorize what FTAGs are, et cetera, but I wanted to give you a sense of why these things are so important. So here, why does it matter? Because we do have, I think, stronger rules. Hopefully, we will have improved enforcement down the road, and then that we hope at some point will lead to better resident care. Before I move on, I wanted to mention also that even though the regulations have changed substantially, a lot of the language has changed, the guidelines, etc., all of the residents' rights that have existed for the past 25 years, in regulations, now 26 years, since 1991, none of them have gone away. So any resident right that you had, that you knew you had last year, or that you read about in language from last year or 10 years ago, that still exists. Nothing has been taken away in terms of residents' rights. If anything, quite often it's been explained, it's been elucidated more, so that hopefully in the future people will be able to realize it better for their residents. So in a nutshell, why is this information important? It's important. The reason why we're doing these programs is because we want people to be prepared and to know what our rights are, what your rights are, as these changes are implemented and beyond, because that process, I fear that a lot of residents will be put into even more precarious situations. So a little bit before we get started with the subject today, a little bit about what we're going to be doing with this program and what we do with all the programs is I'll talk about some of the federal language, some of the new language you'll see, as well as what's existed for 25 plus years. We'll summarize some of the important points, and then at the end, we'll have the fact sheets. And actually, I use the fact sheet as a way to summarize some of the important points that we talk about. And again, all of this information is or will be on our website in the next 2 days. So there's no need to worry about remembering. What I really want to do with these programs, for those of you who are able to attend live, and we appreciate that, is to really plug in with you on what's going on, why this is something that, or these are things I should say that are important for resident advocacy, for quality of care, et cetera, and so that you know that these resources are available in the future. So the standards that we're going to be talking about today are requirements for protecting residents from abuse, neglect, and exploitation. The focus really is on some of the most relevant abuse and neglect requirements. Why are we talking about these requirements? Some of you, or probably everyone here, has heard on the news recently about the Florida nursing home. And here I have, the Fox News headline, Florida nursing home deaths, criminal investigation. 2 headlines in orange in the middle. There was a report that came out just about a week and a half ago from the U.S. Office of Inspector General for the Department of Health and Human Services. They issued what they call an early alert because they were finding and looking at information, data on nursing home residents that were sent to the ER and that it looked like they were the subject of abuse, including sexual abuse, some of these residents, that 25% of those cases were not reported as required by federal and state law. So they're still doing that analysis, but they were so struck by what they were finding that they issued what they call an early alert to CMS, the federal government, saying, we need to be doing something about this. And then lastly, CNN did and this is just a few of the many, many reports that we see, but lastly, CNN had a report a couple of months ago, sick, dying, and raped in America's nursing homes. And that's unfortunately an issue that we are hearing more of sexual abuse going on in nursing homes, and certainly there's other types of abuse going on as well. And fundamentally, as I put at the bottom, we're talking about this because too many nursing home residents suffer abuse and neglect, and far too often it's unrecognized and unaddressed. No one's held accountable for it. So here are some of the federal requirements for freedom from abuse, and that's how they put it, freedom from abuse, neglect, and exploitation. So at the top here I have, and again this is going to be on the fact sheet, I always give people, 42 CFR is from the Code of Federal Regulations. I always want you to have what the code is, so you're not saying, oh, Richard said this, or some guy did a training on it. You can always go back to the code. It's always there to see that, this is based in the law and based in the regulation. And then for your information, that's the new F-tag, the F600. That's the F-tag that I mentioned earlier that's changing as well. So, for instance, if you're in the future, you're looking at your nursing home in your community, et cetera, and you want to see if they've been cited for this, you can come back to our materials to see what the requirements are, what they spell out, and what the citation is to see if that has happened to your nursing home. And just lastly, as you can see on the side, anything that you see in orange in these and the next several slides, that's all new regulatory language. So I highlighted that in this way so you can really see how the federal government is trying to, I think, really address some of the issues we see in a way that strengthens the standards or the implementation, hopefully, of those standards now and into the future. So, basic federal requirement. The resident has the right to be free from abuse, neglect, misappropriation of resident property, and exploitation. This includes, but isn't limited to, corporal punishment, being hit, being pushed, etc., involuntary seclusion, any physical or chemical restraint not required to treat the resident's medical symptoms. I added some things here that I thought were important next. One is the intent of the federal requirement. This is, again, from the federal language. You can see everything in italics is not what I'm saying. It's what the CMS, the Centers for Medicare and Medicaid Services, is saying either in the regulation or in the guidelines. And here, the intent of this federal requirement, quite simply, is each resident has the right to be free from abuse, neglect, and corporal punishment of any type by anyone, period. So really, the rest of what we're going to talk about today is, well, what does that mean? What does that mean when we talk about resident-on-resident abuse, or someone hurt someone else? What does it mean if it's staff, and the staff person reacts to a resident, or says he or she reacted to a resident by slapping or pushing her? What does that mean? So we're going to talk about that, but basically it's right here. Every resident has the right to be free from abuse, neglect, and corporal punishment of any type by anyone, period. I added below some of the key elements of non-compliance for abuse and neglect. An important, very important component of all this, of course, is that how are nursing homes going to be held accountable for meeting these requirements for their residents? So what I included here, I thought this was really valuable. The facility is basically, these are the elements of non-compliance. So what does a surveyor look for? What should we be looking for? The facility failed to protect a resident's right to be free of any type of abuse, including corporal punishment and neglect, that results in or has a likelihood to result in physical harm, pain, or mental anguish. All three of those things: physical harm, pain, mental anguish. Or the facility failed to ensure that a resident was free from neglect when it failed to provide the required structures and processes in order to meet the needs of one or more residents. And I thought that was really interesting and valuable, because it talks about the required structures and processes. It really, I think, puts the ball entirely in the court of the nursing home to say, you know what, you have control of who you hire. You have control of the physical building, the physical plants, the services, who comes in, etc. You have to, this is a very vulnerable population. You have to have the structures in place. You have to have the processes in place. You have to, these people are generally very vulnerable 24 hours a day. You have to make sure that they are protected. I wanted to include some definitions here, as you can see on the side. So what are we talking about? What is CMS telling us as consumers and as advocates? What are they telling government officials? What are they telling nursing homes? This is what we mean. So abuse, it's the willful infliction of injury, unreasonable confinement, and by that, it means that sometimes people are put in a room because they may be annoying, they may be having behavioral issues, that they're acting out in some way, and they could be, I've heard about this before, that if someone is sent, is wheeled into a room and the door is closed, and that's it. That's unreasonable confinement. They're free from intimidation or punishment which results in physical harm, pain, or mental anguish. Again, mental anguish. It's just too often, I think, we hear that, if it's not a physical, if it's not a physical injury, that it doesn't count. But CMS, as you can see, is saying over and over again, mental anguish. Abuse also includes the deprivation by an individual, including a caretaker, of goods or services that are necessary to attain or maintain physical, mental, and psychosocial well-being. So again, it gets to that physical, mental, and psychosocial well-being. That is what every resident is entitled to. And here, what they're saying is that abuse includes not providing that, failing to provide that. I put in bold, and this is new language in orange, instances of abuse of all residents, irrespective of any mental or physical condition, cause physical harm, pain, or mental anguish. It includes verbal abuse, sexual abuse, physical abuse, and mental abuse, including abuse facilitated or enabled through the use of technology. What are we talking about here? Two things. In the first sentence, irrespective of any mental or physical condition. That means that if you have someone with dementia and you speak to them disrespectfully or in a humiliating way, CMS is saying here and in other places in the guidance and in the regulation that that person counts, that you have to consider that person as a person that might be, that would have the cognition, etc., to understand that just because, let me put it another way, just because a person may not understand doesn't mean that it's okay to speak to them disrespectfully. It doesn't mean that it's okay to be emotionally abusive of them because they may not they may not be able to comprehend it. That is not relevant. What's relevant here is the abusive behavior. And then secondly, when we talk about the use of technology, that we're seeing more and more, unfortunately, it's very upsetting to me, and I'm sure to others, we're seeing more of these cases where people, the nurse aides or others are using Snapchat to take humiliating pictures of residents, sometimes residents who are sitting in their waste and feces, sometimes residents' genitals, etc. So that is a form of abuse. And again, it has nothing to do whether or not the resident is capable of understanding or capable of comprehending that he or she is being embarrassed or humiliated. What matters is that this is done, and it's a bad thing. So quickly, I'll go through the other definitions here. Neglect is the failure of the facility, its employees, or its service providers to provide goods and service to a resident that are necessary to avoid physical harm, pain, mental anguish, or emotional distress. And again, this is an issue that I know I've been thinking about and talking about for years. And I remember there was one case, a deficiency that I came across many years ago, that the resident was, a doctor diagnosed her as being deaf and prescribed a hearing aid for her. And 8 months after the doctor had done that, the surveyor came in and she noticed on the medical record that she had not ever been given a hearing aid. And that was cited as not causing the resident harm. And I think to myself, and I've said this to others, and can you imagine being moved to a nursing home, being in this strange place? Think about your typical nursing home setting, and you have a roommate, etc. Your TV is, probably a big thing for people. Obviously, any opportunity you have to communicate and talk with the people who care for you, with other residents, etc. If that is all shut out for you, because you can't hear, and you're so isolated for I think it was 8 months, that is harm. That to me is really clearly harm. So I think it's important that they got it this year. Again, you can see all the new language in orange. Sexual abuse means the non-consensual sexual contact of any type with a resident. And then willful, and this is really important because willful is important to abuse. Willful means that the individual must have acted deliberately, not that the individual must have intended to inflict injury or harm. So the difference is, and they talk about this, I think I include this in some later language, but essentially, if I do something willfully, it means that I am taking the action, knowing I'm taking the action. It doesn't matter whether or not I intended to hurt someone by that action. Whereas unwillful means that if someone has a spasm, for instance, that's not a willful act. What's important there, by the way, just before we move on, is that it really means that the fact that whoever was the perpetrator of the harm, the fact that they did not mean to cause harm is not relevant here. It's the fact that they actively did something. Here are some excerpts from the guidelines that I thought were important. One, right on top, all in bold. What is the facility responsible for? The facility must provide a safe resident environment and protect residents from abuse, period. And then what I included here, because I thought this was really interesting, facility characteristics associated with increased risk of abuse. And this is what I'm always saying in my advocacy. Not that a nursing home that has one of these characteristics should automatically be cited, but it should be a heads up to surveyors, it should be a heads up to us as advocates, as ombudsmen, as family members, and as residents, what is going on if we're seeing some of these things. So I wanted to include them here. Identified facility characteristics that could increase the risk for abuse include, but are not limited to, again, this is all CMS language, unsympathetic or negative attitudes towards residents, chronic staffing problems, lack of administrative oversight, staff burnout, and stressful working conditions. Bless you. Poor or inadequate preparation or training for caregiving responsibilities, deficiencies in the physical environment, and facility policies that operate in the interests of the institution rather than of the residents. So all of these things are, to me, things that we talk about and that we think about and that we see over and over and over again, but I have never before seen them identified in this way by CMS. This is what we know is associated with poor care. We know that when I go into a resident, when I talk to family members, or when I talk to ombudsmen, or when I talk to residents, they know that. But here we have, in a systemic way, that CMS is identifying that. So now I'm going to talk about a couple of the specific areas of abuse. One is staff to resident abuse. So again, this is all excerpted from the federal guidelines, not things that I've made up or I'm saying. So I want to read it. Nursing homes have diverse populations, excuse me, including, among others, residents with dementia, mental disorders, intellectual disabilities, ethnic and cultural differences, speech or language challenges, and generational differences. When a nursing home accepts a resident for admission, the facility assumes the responsibility of ensuring the safety and well-being of the resident. I would like to have this tattooed to my forehead because it would make my job a lot easier. This, to me, it says it all. This is what we expect. This is what we know, that nursing homes, of course, have residents with dementia. I can never understand why so many nursing homes need training about how they don't know how to care for a resident with dementia. That's most residents. Most residents we know have dementia. This is part of the population, so it's not an excuse to say, oh, I did not know what to do. Second paragraph, it is the facility's responsibility to ensure that all staff are trained and are knowledgeable in how to react and how to respond appropriately to resident behavior. All staff are expected to be in control of their own behavior, to behave professionally, and should appropriately understand how to work with the nursing home population. All staff. And then here, again, I put it in bold, a facility cannot disown the acts of staff. Period. And then just a little explanation here. CMS does not consider striking a combative resident an appropriate response in any situation. It is also not acceptable for an employee to claim his or her action was, quote unquote, reflexive or a knee-jerk reaction and was not intended to cause harm. Retaliation by staff is abuse, regardless of whether harm was cited, and must be cited. And that's why I include that in bold, because those of you who are familiar with our organization, we always are looking to ensure that when there is abuse, when there is neglect, why aren't facilities cited to the extent we see abuse and neglect? So I was really glad to see that here it says, regardless of whether harm was intended, the facility must be cited. I don't think it could be any clearer. Here we're going to talk a little bit about resident-to-resident abuse of any type. This is an issue that is getting more and more attention. But a resident-to-resident altercation should be reviewed as a potential situation of abuse. When investigating an allegation of abuse between residents, the surveyor should not automatically assume that abuse did not occur, especially in cases where either or both residents have a cognitive impairment or mental disorder. What are they saying here? That if you have someone with dementia or you have two people with dementia and there has been an altercation of some kind, don't dismiss it. This could still very well be an abusive situation. It is a situation that's not permissible. When we dismiss things like that, we're saying essentially it's okay. We're telling nursing homes it's okay. We're not going to cite for it. Here, CMS, and again you can see it's all orange because it's all new language here, is saying no. Having a mental disorder or cognitive impairment does not automatically preclude a resident from engaging in deliberate or non-accidental actions. And you can see below, I talk a little bit about that explanation here. In determining whether F600, that's the FTEC, free from abuse and neglect, should be cited in these situations, it is important to remember that abuse includes the term willful. The word willful means that the individual's action was deliberate, not inadvertent or accidental. regardless of whether the individual intended to inflict injury or harm. So here's an example. An example of deliberate willful action would be a cognitively impaired resident who strikes out at a resident within his or her reach, as opposed to a resident with a neurological disease who has involuntary movements, muscle spasms, etc., and his or her body movements impact a resident who is nearby. So this is important. Why is this important? So here are the two scenarios. If it is determined that the action was not willful, not a deliberate action, the surveyor must investigate whether the facility is in compliance with the requirement to maintain an environment as free of accident hazards as possible, and that each and every resident receives adequate supervision. In all these scenarios, again, as I said earlier, the facility, when they take in a resident, they agree to provide the appropriate monitoring, the appropriate care to meet his or her needs. And those are the other residents in the facility. The facility may provide evidence, this is again from the surveyor perspective, what they're telling the surveyors and inspectors. The facility may provide evidence that it completed a resident assessment and provided care planning interventions to address a resident's distressed behaviors such as physical, sexual, or verbal aggression. However, based on the presence of resident-to-resident altercations, if the facility did not evaluate the effectiveness of the interventions and staff did not provide immediate interventions to assure the safety of residents, and the facility did not provide sufficient protection to prevent resident-to-resident abuse. So here, I think CMS is really making clear, and I think this is really important, that even if they had a care plan, even if they did the assessment, that is not enough. This is an ongoing basis of duty and of requirements to protect the residents. If the facility, I'll read the last part again, did not evaluate the effectiveness of those interventions and the staff did not provide immediate interventions to assure the safety of residents, then the facility did not provide sufficient protection to protect residents. Excuse me. To me, it's so important that they are really spelling out here, and that's why I wanted. I know it's a lot of text here, but I really wanted to focus and get across that we're hopefully seeing a different way or a better way of how we're approaching our expectations and how those expectations are to be met. So I wanted to end with something else that is somewhat related to this. It's crimes against nursing home residents. And this has been in the news as well with the U.S. Inspector General's alert coming out last week. And it's an issue about which we've been very, very interested in and very concerned about. So, you know, from our perspective, for so many nursing home residents, they walk into the door of a facility and it's as if they're no longer citizens or residents of the United States. You know, the same laws, the same protections that we have as citizens don't seem to apply. And that is not the case legally. Unfortunately, it's too often the case in practice. So the Affordable Care Act, so-called Obamacare, established a requirement for people who work in or own a nursing home that's essentially a duty to report any reasonable suspicion of a crime that's been committed against a resident of the facility. And this applies to everyone. As I said, the owners, every single employee, from the administrative staff to the laundry staff to the contractors that come in to, of course, the nurses and the nurse aides, to the PT staff, etc. Everyone. This applies to everyone, the kitchen staff, etc. Applies to every single person, including their agents and including contractors. When do they have to report? They have to report any reasonable suspicion of a crime immediately. It has to be within 2 hours if the act or incident that is suspected to be a crime resulted in physical injury to a resident. Otherwise, it's within 24 hours. So they're supposed to do it right away, but if they don't do it within 2 hours, if they suspect physical injury, or 24 hours, otherwise within 24 hours, even if there's no injury, then they can face a penalty. They have to report to both local law enforcement and the state survey agency, the Department of Health. If they don't report, they personally face a fine of up to $221,000. And if the failure to report results in increased harm to the victim, to the resident, or harm to another resident, that fine could be up to $331,000. We and other advocates worked so hard to get this into the Affordable Care Act in 2009, 2010, and we succeeded. Unfortunately, this is not a standard that has been very well implemented. But a week and a half ago, that U.S. Inspector General report, that's what they were talking about. That's one of the things they were talking about, and they said that you need to move on this. And so hopefully we'll see some action. This regulation, this standard has existed for 7 years now. There's more language about it in the new regulation, but I want everyone to know that if there's a reasonable suspicion of a crime, everyone in that nursing home has a responsibility. And if one of the aides tells the administrator, the aide still has a responsibility to tell both local law enforcement and the Department of Health, and so does the administrator. So I'm going to end pretty much with a chart that I put together, and we'd be happy to share this. It's in some other materials that I put together last week on that Inspector General report. But here's a chart of who is required to report and why. So you can see the first column, and it shows the first line, I should say, shows the regulation and the associated FTAG. So the first column going down relates to any suspicion of a crime. The second column is an allegation of abuse, neglect, exploitation, or mistreatment. So you can see who is required to report to, who they have to report to, and when. And the when is pretty much the same, immediately. And within 2 hours if there's bodily injury, or within 20 hours if it does not involve a bodily injury. And my guess is, unfortunately, this is going to be a surprise to a lot of people who may not realize that abuse, neglect, exploitation, whether or not one suspects it's at the level of a crime, that has to be reported, and it has to be reported fast. So I'm going to summarize really quickly, and this is a copy of the fact sheet. It's now on our website, so you're free to download it. If you're on our mailing list, you'll get copies of this. And if you want to be on our mailing list, again, please email Sarah, S-A-R-A, at LTCCC.org, and we'd be happy to send these out to you. So what I just did here is I just highlighted some of the things that we talked about. So the basic, you see on the left-hand side, number one, the basic rights to be free from abuse, neglect, and exploitation. Again, the citations of the 42 CFR, so that you know what it is that you can look, where it is to go if you need more information or you need this validated. Key elements of noncompliance, because I thought that was so important. And what are we looking for in a facility when we say they're not meeting this standard? It's that they're failing to ensure that every resident is free from any type of abuse or neglect, that they're failing to ensure that a resident was free from neglect by not providing the required structures and processes to meet those needs, to ensure that safety. I included the key definitions here, so we have the definition again of abuse, how abuse includes the deprivation by an individual, or including a caretaker, of services or goods that are needed to attain or maintain that person's highest physical, mental, and psychosocial well-being. Talks about the instances of abuse, including verbal abuse, sexual abuse, the use of technology as a form of abuse, neglect, what sexual abuse means, what willful means, because I remember that was something that we really stressed, is that abuse itself has to be willful. Neglect does not, but abuse means something that was willfully done. And then on page 2, I included those facility characteristics, not just because they're associated with risk or abuse, because they're associated with facilities that I think one should really be concerned about. If you're seeing chronic staffing problems, if you're seeing unsympathetic or negative attitudes towards residents, a lack of administrative oversight, staff burnout, inadequate preparation or training for staff, deficiencies in the physical environment, and lastly, which is so important, facility policies operating in the interest of the facility rather than of the resident, well, that should be a signal to all of us, no matter where we are, whether we're the resident, family member, ombudsman, other advocate, someone who's working in government, including surveyors. What is going on here? We need to look a little bit further into this facility, because these are some characteristics that are send a sign that something may be going on that's bad here. And then what I did is I just, in a different way, put together that chart. So you can see here, first, what the requirements are for reporting any alleged abuse, neglect, exploitation, or mistreatment. This is the middle of the second page. And then the requirements for reporting suspicion of a crime against a nursing home resident. So you can feel free. Again, we have this on our website. We're sending hard copies out to our mailing list, but you can use this. You can share this with resident councils, family councils, with other ombudsmen in your programs, with other advocates. If you find, I'll go back up to it quickly, if you find that it's useful and you want to take the text and incorporate it into your materials, I am perfectly fine with that. Use it any way that you see fit. What's important to us is that this gets out there in terms of protecting residents from abuse and neglect, and making sure that allegations of abuse, neglect, crimes against residents are identified and reported. So thank you everyone for joining us. Our next program will be October 17th, again at 1 p.m., same dial-in information. We're going to talk about Nursing Home Compare and how you can find and use information about nursing homes using Nursing Home Compare. There's a lot of changes going on with Nursing Home Compare as well that we'll talk about. And then at the bottom here, lastly, for the long-term care ombudsman in New York State, as I mentioned before, we're able to tell your supervisor, if you attended this program, just take this survey. It's www.surveymonkey.com/r/LTCCC-LTCOP1. This will also be on our website, so you can find it there. And then for family members, family council members and family members in New York State, I strongly urge you to connect with the Alliance of New York Family Councils. It's a great group. We're meeting tonight. www.any, F as in Frank, C as in Carol.org. And then I'm going to open it up for questions and comments. So thank you all very much for attending. I know some people need to get off, but we're going to unmute everyone. We'll see how that works. Hi. So any questions?
Yes, I have a question.
Okay.
What was the what was the address for Sarah at LTC.org if you wanted to get on the mailing list?
Sure. It's Sarah, S-A-R-A, at L as in Larry, T as in Tom, CCC.org.
And that's 3 C's, CCC?
Yeah, 3 C's as in Carol.
All right, thank you.
Sure, thank you.
Joanne Ramsey, thank you.
Sure, thanks. Any questions?
Yes, I have a question.
Hi.
I have a question relating to the nursing home reform law to attain and maintain highest practicable physical, emotional, and social well-being.
Okay.
I know none of us can predict the future, but the Medicaid cuts are very frightening, the potential cuts. And how can that affect that? In other words, suppose they say we can't maintain quality of life services. We certainly can prevent abuse and neglect and exploitation, but we don't have the money to provide X, Y, or Z therapy. Medicaid has been cut. What is your response to that, and can we be proactive in preventing such cuts?
Well, that's a really good question. I have to tell you that I do a lot of reading, and I was reading the testimony of regarding the long-term care ombudsman program in the Senate Special Committee for Aging. I think it was from the late 70s, like 1978, and they were talking then about providers saying that it wasn't fair to hold them to certain standards because they don't get enough money to provide those services. So my reason for saying that is that we've heard this argument now. The 70s is well before my time as a professional, But we hear this argument over and over and over again. And, you know, my feeling, frankly, is that the industry quite often, you know, they take in elderly people and people who are with disabilities who need 24-hour-a-day professional care, and then they're kind of held hostage. But as I said at the beginning, when a facility takes in a resident, they are promising that they can provide the care and the services that they need to keep that resident safe and to provide her with the highest practical, you know, the care necessary to be the highest practical physical, emotional, and social well-being. So, when it comes specifically to the changes to Medicaid, most of them, I mean, you know, there's different proposals, of course, but most of them relate to block granting Medicaid. So what we'll probably see, and this is something that we're certainly fighting, is that there'll be a diminishment in people being able to long-term care services outside of nursing homes, because a lot of the monies that you know, additional monies over the years that have gone to the states for Medicaid services has been to help people get care outside of a nursing home. But the nursing home care in and of itself has always been a guaranteed you know, right. If you need 24-hour-a-day care and you're on Medicaid, you can go to a nursing home. The other thing is that a facility is making those promises and agreeing to meet their standards, period. So if they're not able to do that, they should not be taking in residents. And
well, we've seen this happen. I'll give you a citation. A few years ago with the Sebelius versus Jimmo lawsuit, where they were supposed to give patients the services that they needed, and they were only doing it very selectively and limiting service, speech therapy, PT, stuff like that, saying that the patient can't improve enough.
Well,
and they were misinterpreting.
No. I don't want to interrupt you, but that's a different issue. The issue with the Jimmo is, and I'm not
it's
expert
Medicare.
But,
yeah.
No, it's not. That's not just that it's Medicare. The issue with Jimmo is that CMS was found, if I understand it correctly, CMS was found to have been misinterpreting and misrepresenting the requirements.
That's correct. They were using it as an excuse.
Right. But it has nothing to do with the provider saying, "Oh, we don't get enough money to provide good services." There is no excuse for that, and there's never an excuse for that.
Okay, so they cannot, with Medicaid cuts, say, well, like that, we can't provide it, just do the same abuse.
Correct. Okay,
I mean,
they can and they will, because they always do that, but they've been doing that for 40 years.
I know.
So, you know, the thing is, and you know, I would encourage you to visit our website, and this is something certainly that we talk about and to talk about more, is how do we counter that? And one way I think is really interesting is that there was an Inspector General study that came out in 2014 that found that even for those Medicare residents, now for Medicaid, the average reimbursement is about $200 a day. For Medicare, it's between $400 and $800 a day, roughly. $400 and $800 a day. Even for those residents, which providers admit that they're making money off of, one out of three of those Medicare rehab patients were harmed within 30 days of entering the facility. And 59% of that harm was a result of inadequate monitoring or poor care. So the point being is that even when they're making a lot of money, they're not being held accountable, and too often, 1/3 of the time, according to the U.S. Inspector General, they are not meeting the needs of their residents.
Hello.
So I hope that's helpful. So obviously a big issue, and but I hope that's helpful.
It is, and what you did today is also, thank you.
Oh, great, thank you.
Hello.
Hi.
May I ask a question? Hello?
Yes.
Okay, how would a facility be held accountable and they didn't document a fall of a patient who had dementia?
How were they held accountable? Be held accountable?
There's so much noise. Would people mute their phones if they're not speaking?
Okay,
I'm having a very hard time hearing the Q&A.
You know what I'll do is I'll mute everyone, and if you want to say something, press *6 on your phone. I hope that'll be easier. Just press *6, but I'll try to answer this question. So essentially, a facility is required to ensure that every resident is safe, that there are services, and that the physical plant of the building and the physicality of the building are tailored to ensure that safety. That's not to say that things don't happen, but the facility, if it was not, I would say, I can't only speak a little bit because obviously it's not an actual scenario, it's more a broader question, but I would say that, if a person had frequent falls and they had not taken the steps to ensure that that resident was safe, that could be a reason for citing them. It could be, if a person was, was prone to that or had a physical condition that left them vulnerable to that, and that was be based upon their resident assessment, that the care plan should reflect the assessment, including a risk for fall. If that wasn't carried out, that could be a place for a risk that they would have to being cited and potentially penalized for that. But it's really not possible, I think, to answer definitively with something like that. But there are avenues. It really depends upon were they again doing these things necessary. Now sometimes bad things happen to everybody in or out of the facility, but there's a special responsibility for nursing homes and for nursing home caregivers because of, frankly, of course, the vulnerability of residents in facilities and the fact that they need 24 hours a day skilled nursing services, and that's why they're there. So I'm sorry I couldn't answer more definitively, but I hope that gave you some insights. Any other questions or comments?
Yes, Richard, it's Mary Cohen, and
Hi.
I'm a New York State Ombudsman.
Hi.
And how are you? And thank you for all the work you do.
Oh, thank you.
My question is regarding not so much the regs, but the reports of things that we report and that get investigated by the Department of Health and the state regulators. I became very frustrated with one of my nursing homes and the fact that their state survey was very ineffective in identifying the issues. In fact, I went so far as to actually interview for a job. I'm a retired nurse, so I interviewed for a job with the Department of Health and basically made it impossible for them to hire me because I don't want to work full time. And I told them that up front. But I said, I told them I was an ombudsman, and they took an hour to talk to me. And one of the things I learned is that you have to be able to prove something occurred or something is ongoing. And if they're not able to identify it at the time of their survey, then they can't cite it. And it was very frustrating. And is there any way, I guess, I know that they are working on their F-tags and how they are going to gather information, but is there any way that we can work with them? And I could tell them how they could identify these issues,
Right.
Do you understand where I'm coming from?
Yes. Well, this is a source of frustration for us, and I think certainly probably everyone who works to advocate and protect residents in nursing homes. This is it's an issue. It's frankly in New York, and it's an issue nationwide that the Department of Health here and elsewhere they tend not to do a very good job in identifying problems, and they also don't do a good job in identifying when a resident has been harmed as a result of deficient care. I mean, the fact of the matter is that this is not Perry Mason, and in a nutshell, too many surveyors are told that they have to treat it like they're Perry Mason, and prove within a shadow of a doubt. And that's just not the right standard. So what happens is, in short, this is something pretty much dedicated my life to. So we have a lot of materials and we do a lot of work, reports around this, which we share with the state and with the federal government and with other states. But the fact of the matter is that there is a burden of proof that they've imposed upon themselves that is not really appropriate in my view, and that does more to protect the nursing homes than it does to protect the residents. And
I agree.
I mentioned in one of the examples I gave of the woman who didn't have a hearing aid and for 8 months, and it was cited as no harm. And I raised that with the head of the nursing home division for the federal government when I met with her a couple of years ago. She's no longer there. But she shared my frustration, and this is something that if you ever go to our website or ever interested in participating in our other in our work, we have action alerts, etc. It's something that really we're always trying to get at. And I don't want to keep you or anyone else, but we did a study earlier this year that found that even when a facility is cited. And as you know, as you discussed, it doesn't happen very often, even for facilities with seemingly a lot of problems. They're often not cited, but even when they are cited, the states only identify resident harm 5% of the time. 5% of the time. 95% of the time, with a health deficiency, they cite no resident harm. And if there's no harm cited, then there's generally no penalty. So
right.
That's really, this is what my organization and what I do. I try to think, I think all the time, how do we get at this issue? Because it's so unfair, and it's the reason why there's so much suffering, to be honest, that perpetuates, and poor care that perpetuates in our nursing homes, because nursing homes are not held accountable when they do a poor job. So unless you're someone who really cares, you're going to do a poor job.
Right.
Companies do what they can, what they can get away with, generally speaking, and that's what we're seeing more and more, frankly, in my opinion, in the nursing home industry. And that's really what we fight against. We're small, and there are other groups like ours that we work with as much as possible. But this is, you hit the nail on the head. It's trying to help surveyors to understand, this is a problem. This is a problem. And if you don't do something about it, it's going to continue to be a problem for more and more residents.
Right. And, right now they're using the excuse that, we're really spending a lot of time on getting what we need to be able to work with their F tags, their list of things that they are going to review. That changes everything for them. So they're in a pickle too. But that doesn't make it any easier in the past couple years of being an ombudsman, showing up for their entrance and exit surveys, giving them copies of my cases, and nothing is done, and nothing is cited. And it's extremely frustrating. Richard, I don't want to take up everybody else's time, but I would love to get in contact with you. So if I go to your website, can I send an email?
Yes, I think so.
Or not.
Thank you.
You're welcome. Thank you.
Sure. Bye-bye now. Anyone else?
Hi, Richard.
Hi, Charles.
It's Charles. Hi. I did make it in time for the webinar. Just to comment on what the caller just said, it's very hard to get the DOH to cite anything, it's true, but there are still ways of working with them that can sometimes work to a resident's advantage. If you can help prepare a resident to make a complaint in an effective manner that will get their attention, you're probably not going to end up with a citation, but what you can often end up with is that the DOH will call the facility and alert them, and that can often go some long ways towards persuading the facility to get its act together. And I've had that happen a number of times. So you have to kind of know the lay of the land with the DOH, what they're good for, what they're not good for, and how to help the resident or the family member use them at least to some partial advantage, even if we can't get everything we want.
Thank you, Charles. Thank you very much. Any other questions or comments? Okay. Well, thank you everyone for attending today. I hope that you found it valuable. As I mentioned, next time we're going to be talking about Nursing Home Compare. It's, I think, the best resource for looking at nursing homes individually, in your community, in your state, and there's some pretty good things happening with improving the information that's on there that I hope will be useful to you. So thanks again, and you'll have a nice afternoon.